Thank you so much for that kind introduction. And I'm absolutely honored to be here with you all and have the opportunity to speak to you about something I'm very passionate about. And I hope you'll walk away from this talk thinking about FMD as much more than just the string of beads. So my disclosures, none of which are really relevant to today's talk. And I have two objectives for you. So first, by the end of this presentation, I hope that you'll be able to identify patients in whom the diagnosis of FMD should be considered. And secondly, to recognize FMD as a condition with heterogeneous presentation and impact. And I'll start with a question. Which of these is FMD? And we'll be answering this over the course of the talk. You've got a focal area of stenosis in number 1, the classic string of beads in 2, some tortuosity of a carotid artery in 3, cerebral aneurysm, and a coronary artery dissection. So going back to the beginning, FMD was first identified in a 5.5-year-old boy with hypertension since age 3, and he achieved a cure with nephrectomy of an ectopic and atrophic right kidney. And on pathology, Ledbetter and Birkeland described this muscle plug in the vessel wall that was in contact with the intima of the artery. And this was the first description of intimal FMD. And they said, it seems obvious that by chance we've stumbled on a peculiar anomaly of development affecting a renal artery. Now, as more time went by in the 60s and 70s, histopathologic data became available on this entity of fibromuscular dysplasia and really described different types based on the layer of the artery wall that is affected. These days, since we rarely obtain pathologic specimens for our patients, we've moved to an angiographic classification system, which is really simply just the multifocal string of beads versus focal single area of stenosis, FMD. And I'll be focusing mostly on multifocal today. Now, there's some important mimickers that you should be aware of. Really, vasospasm or standing waves, and I have a few examples here, both on catheter-based angiography as well as CTA. You can see that the beading, quote unquote, in these images are very regular in their distribution and their size. That is vasospasm. That's the giveaway for that. And if you administer a vasodilator, it will normalize. But important to know, you can also see this on CTA and MRA, so it can be an important mimicker to be aware of. And then finally, dissection. Healing dissection as the artery wall remodels can have an irregularity in its appearance that can sometimes be mistaken for FMD, although it's often more aneurysmal in its irregularity than the typical beads of FMD. So what do we know about this disease? Well, it's non-atherosclerotic, non-inflammatory. It usually affects the mid to distal artery, which distinguishes it from atherosclerosis. Predominantly affects women in the prime of their life, but men and people of any age can be affected. We've diagnosed people as young as 3 days old with renal artery FMD. Usually we'll find it in the carotid and renal arteries, but again, any artery can be affected. And the etiology and true prevalence of this really isn't known, but I'm going to make the argument that it's much more common than you think it is. So this is some data on multifocal versus focal FMD. Focal FMD tends to affect the younger patient. Multifocal, more kind of 40s, 50s, and beyond is when they're typically diagnosed. We see men affected more frequently with focal disease. And so that's another important distinguishing feature. Now, in terms of why this happens, there's a lot of different theories that have been postulated. Some of them surrounding environmental triggers such as estrogen, since this is something that affects mostly women. But when you look at women on OCPs or differences in parity with FMD versus matched controls, there really is no difference in the rate of FMD. So it hasn't panned out. We do know that patients who smoke have a higher rate of aneurysm and they tend to have more severe FMD. So that does seem to play some role. Mechanical stress points is an interesting idea. So we know that in the renal arteries, the right renal artery is most frequently affected. It's the longer of the two arteries. When you breathe, the kidney arteries do move. So perhaps there's some kind of traction that's happening at these mechanical stress points. Same with the mid to distal carotid artery with head turning. That might lead to the development of this condition. The genetics are another fascinating area of this. So familial cases in the literature reported in up to about 11%, but when you look for other monogenic diseases, they're very low rates. This was a really cool case report of identical twins who both had FMD, but different areas of involvement, different areas of aneurysm formation. So clearly there's more at play than just the genetics to this and the manifestations of the disease. So I have 4 pieces of evidence to support that FMD is not as rare as you think it is, or at least not as rare as we were taught in medical school. First is data from healthy kidney donors. Second, data from the CORAL trial, which is an atherosclerotic renal artery disease trial. 3, incidental findings on imaging performed for other reasons, and then patients that have presented for other reasons to our clinics. So looking first at the donors. There's several studies looking at patients who underwent screening to be a renal donor, finding incidental FMD in up to almost 4% of those patients, either by renal angiogram or CTA. So if you put that to the US population, that means that over 6 million women in the US probably have FMD using these numbers. If we look at patients with hypertension in the CORAL trial, which again was atherosclerotic renal artery disease trial, FMD was actually an exclusion criterion. These patients with hypertension were being randomized to medical therapy versus stenting. When the core lab reviews the imaging for the patients that were included, they found FMD incidentally in 5.7% of patients included in the trial. If you looked at just women, that was 9%. So I think it's definitely much more common than we think it is. Incidentally, at our institution, we pick up 1 to 2 cases per month on imaging for patients who are getting an evaluation for something completely different. In this MRA, you can see multifocal FMD affecting the right renal artery. And then patients who are referred to us for completely different reasons. We've identified over 30 patients now who are sent to see us for everything from leg swelling, varicose veins, pulmonary embolism, cardiovascular prevention, vasculitis, or even as a healthy control for our DEFINE FMD trial, simply by listening to the neck. And you have to listen high up because, again, FMD is mid to distal artery. So if you listen at the base of the neck, you're not going to necessarily hear the bruit. You got to be up by the angle of the jaw, ask the patient to stop breathing sometimes to hear it. This is an example, a 74-year-old woman who was sent to us with leg swelling, found to have cervical bruit on exam. What you're looking at is B-flow imaging of her internal carotid artery. You can see there's a loop here and luminal irregularity in this part of the artery, as well as on the other side, you can actually see the string of beads. And tortuosity should not be underestimated, particularly for your patients under age 70. This was a really cool study that Dr. Olin did a number of years ago, looking at duplex ultrasounds of patients with FMD who were matched to 2 different control groups, one that was age and sex matched and one that was age over 70 and sex matched, to see about the rate of this so-called S-curve and its relation. And what it found was that if you were under age 70, you were far more likely to have FMD. All of these odds ratios are compared to FMD as opposed to if you were over age 70. So the S-curve, particularly if you're under age 70, may be a sign of an underlying arteriopathy. So I wouldn't discount it. I'm going to talk to you more about the role of arterial tortuosity and arteriopathies in general, and that we should be paying attention to this finding. So now we have the North American Registry for FMD, updated name now that it's included Canada from the US Registry for FMD. And this amazing center became a member of that coalition of forces over the summer last year. So we now have over 4,000 patients enrolled in this registry, 19 different centers included. And because of this registry, we've learned a lot about FMD. So, sorry about that. So some findings from FMD research, both in the US and then elsewhere. In the US registry versus European and international, as well as the Arcadia, which is really out of France, Belgium, and Poland, I'm going to highlight some differences across the findings here. Basically, it definitely affects women much more likely than men, mostly multifocal disease. Multivessel involvement is frequent, over 50% of patients. There are some differences in the locations of involvement. Why is this doing this? Okay. So in the US registry, we have a fair number of cerebrovascular and renal artery involvement, whereas the other sites outside of the US, much more renal artery involvement. I think this highlights some of the limitations of registry research. Most of the patients in those centers are recruited through hypertension centers, and so we're seeing some of that creep into the data. It's definitely not just a disease of the renal arteries. Aneurysm and dissection rates, almost a quarter to a third of patients in the US registry, a little lower on the aneurysm side in the other registries. Important to know, though, that people are not getting systematic imaging of all the vascular beds, so that might be underrepresented, and I'll talk a little bit more about that. When it comes to FMD, your manifestation really depends on the artery that's involved. So if you have neck artery involvement, headaches, pulsatile tinnitus, very common, cervical bruit, any ischemic type symptoms are usually related to dissection. Renal artery, far and above, hypertension is the presenting sign of FMD. And then about 6% or so have FMD identified incidentally in the US registry. So this was an analysis that we did right when I was coming out of my fellowship, looking at the rate of aneurysm and dissection overall in the US registry. And what we found was that 42% of patients had an aneurysm and or dissection in a vascular bed. So this is now being recognized as a manifestation of fibromuscular dysplasia, distinct from the string of beads or the focal FMD. But many other things cause aneurysm and dissection. So the only way you can tell the patient their aneurysm or dissection is due to FMD is if you see that pathognomonic multifocal beading or focal stenosis in another vascular bed. When you look at the breakdown of where these findings occur, we find it mostly in the renal and carotid arteries, which are the major areas of involvement, followed by cerebral arteries for aneurysm, mesenteric arteries, and surprisingly, aorta, I want to draw your attention to, 10% of aneurysms. Again, keep in mind, these are women mostly, middle-aged, not, otherwise without cardiovascular risk factors. So kind of an impressive number of aortic artery aneurysms, and they're typically in the thoracic aorta. When you look at cerebral aneurysms specifically, this was data from almost 700 patients from the US registry who had brain imaging. The rate of cerebral aneurysm is much higher than the general population. So we identified 12.9% of patients with a cerebral aneurysm in the US registry for FMD, compared to nearly 3.2%, which is the estimated prevalence in a population without comorbidities in the United States. Most of the aneurysms that were identified were pretty high risk too. They were in the posterior circulation and they were pretty large. So screening for this, I think, becomes very important. And that's why every single patient with fibromuscular dysplasia should be getting head to pelvis imaging, preferably with a CTA, to screen for other areas of involvement, aneurysms, and dissections. And the reason why I push for CTA over MRA, particularly below the neck, is motion artifact will sometimes mimic the beads of FMD, or you'll miss smaller aneurysms. So CTA tends to have better resolution as a one-time screening test for that reason. So what about dissection? Well, dissections are usually identified in the neck arteries, carotid and vertebrals, followed by the renal and then coronary arteries. And we're going to talk about SCAD a little bit more. And you can see here a double lumen in a vertebral artery, as well as on duplex ultrasound, the single versus double lumen and return to single lumen present there. When you look at how patients are presenting with aneurysm dissection or neither in FMD, the dissection patients tend to present younger, not surprising. They probably get a workup because they've presented with a sentinel event. Men, although they're a small number of FMD patients overall, when they do have FMD, they tend to experience dissection more, tends to be more virulent in them for some reason. We did see an association between tobacco use and aneurysms as well. And then again, most of the ischemic symptoms were reported in patients that had dissection. Again, not totally surprising. This is just another slide highlighting that although men are the minority, when they do have FMD, they have much higher rates of dissection and aneurysm as compared to women with FMD. So this was a really cool study, came out of Europe, looking at patients with spontaneous renal artery dissection. And again, I want you to try to start to think about all of these entities as connected, which is why I'm going here. So this was a study of 61 patients evaluated at a hypertension center. All the patients underwent head to pelvis imaging after their renal artery dissection. What they found was about 26% of those patients had FMD. About 40% almost had isolated renal artery dissection. And then another group, a third of them, had multi-site aneurysm and dissection without FMD findings, so other vascular findings. Only the isolated renal artery dissection patients had unilateral dissection. If you had bilateral, you fell into the FMD or multi-site group. There was no real difference in the age of diagnosis or rate of men. But they followed these patients for 51 months. And what they found was that if you had FMD or multi-site aneurysm and dissection, you experienced recurrent events, whether it was within the renal system or extrarenal arteries. Whereas if you had an isolated renal artery dissection, you did not have a recurrent dissection event. So by screening, we may be identifying a higher risk population, and it may help us with the prognostication and management of these patients. As is pretty common for most dissection patients, the majority had complete healing with just conservative management. Some had some aneurysmal dilatation, but the majority remained stable and did not require intervention. So most of the dissection patients generally do well if you just leave them alone. This is the breakdown of the past, present, and new dissections in these populations. And you can see again that there was a high rate of supra-aortic trunk involvement, digestive, lower limb arteries, and aortic involvement in the patients with either multi-site aneurysm and dissection or FMD. And that leads me to kind of the changing phenotype or understanding of FMD as a spectrum. And I have a family that I follow to kind of use as an example of this. So there's going to be 3 sisters. This first sister is your typical kind of FMD patient, 47-year-old woman with hypertension, carotid bruit on exam. She gets a duplex. You can nicely see on B mode, there's some beating of her mid to distal artery and then the turbulence that goes along with it. She ended up getting a renal angiogram, which also showed multifocal FMD. Now, her sister had a spontaneous coronary artery dissection at age 45. She got screened and we found carotid multifocal FMD. Now there's a third sister with no symptoms, but because of these 2, I just went ahead and imaged her. She has only splenic artery aneurysms, nothing else. So had I not known about the other 2 sisters, I couldn't tell this sister that she has FMD, but given the whole picture, I'm very suspicious that this is a spectrum of FMD. And then very interestingly, their mother had a diagnosis of Takotsubo cardiomyopathy in the 1990s. We couldn't get the angiograms, obviously, to review it, but highly suspicious that she may have also experienced SCAD. So this third sister is very interesting, and I'm seeing a lot more of this. These are the patients that I call FMD-like, or arteriopathy and NOS. Basically, on paper, they look like an FMD patient. They're usually women, otherwise healthy, no cardiovascular risk factors, but they have arterial dissection, aneurysm, and or tortuosity without the multifocal or focal FMD. You have to have negative genetic testing to say for sure that you're FMD-like. Make sure you don't have some other heritable arteriopathy. So it's a diagnosis of exclusion, but it's important to keep in mind when you're seeing these patients. So we've heard a lot about the overlap between spontaneous coronary artery dissection and FMD over the last years. Coronary artery dissection accounts for about 35% of MI in women under the age of 50. It's the most common cause of pregnancy-associated myocardial infarction, but PSCAD accounts for a low rate of SCAD overall. And it's usually either this kind of inside out or outside in disruption of the arterial wall layers that leads to either intramural hematoma or an actual intimal flap that you can see. And about 50% or so are associated with some kind of precipitating factor. whether it's intense exercise, emotional stress, recreational drugs, or exogenous hormones. Now, Takotsubo has been identified as potentially being a manifestation of SCAD, particularly when you have a wraparound LAD. It can mimic the appearance of that apical ballooning. So important to keep in mind. And there is evidence that SCAD alone is an arteriopathy by itself. So in studies that have looked outside of the coronary bed for other arterial findings, FMD is the most common finding, seen anywhere from 20 to 86% based on the population you're looking at. I would say it's probably more in the 30 to 40% range realistically. If patients get head imaging systematically, one study reported 14% with intracranial aneurysm. And arterial tortuosity is very common in both the coronary and the extracoronary arteries, again, supporting an underlying arteriopathy. And so for this reason, any patient with SCAD also is recommended by the guidelines to get that head to pelvis imaging. This vessel redundancy has also been reported in the cervical arteries. This was a study looking at cervical artery dissection patients versus over 100 age and sex matched controls. And they found that the vessel redundancy, whether it was loops, coils, kinks, S-curves, was present with far more frequency in patients with cervical artery dissection as compared to controls. And breaking down a little bit more about the FMD and cervical artery dissection overlap, usually if you look at the cervical artery dissection literature, FMD is reported in up to 20% of patients when they're screened, but the big caveat is most of them are not looking below the neck. Multiple cervical artery dissection has been reported in patients from this CADIS consortium, which is an international group looking at cervical artery dissection. And they found that if you had this multiple cervical artery dissection, you were 4 times more likely to have FMD. And then coming from the registry data, we also saw that about 19% of patients experienced a cervical artery dissection, and many of them were multiple cervical artery dissections. So there's been this signal. And then we have a small study from the Arcadia Pol group in Poland who looked at patients with FMD suspected or diagnosed, cervical artery dissection, and SCAD. Those patients got systematic imaging head to pelvis. And they found that for the 43 patients enrolled with cervical artery dissection, about 39% also had FMD. So there's definitely clinical overlap present here. So for any patient with a peripheral artery dissection, I hope I've made the case that we should be getting head to pelvis CTA on all of those patients, preferably with CTA again, to look for FMD, but also other areas of dissection and aneurysm, because again, it may help us to prognosticate for those patients. It may help us identify what we should be keeping an eye on. And it also might help with family planning. Again, we're dealing with a lot of women here. And we finally are starting to get some genetic information to support the clinical overlap that we've been seeing. So this factor 1 locus is a member of the phosphatase and actin regulator family that plays a role in actin and contractile filament organization. A top variant seems to have kind of bidirectional behavior. So if you carry this A allele, you're at increased risk for cervical artery dissection, FMD, and migraines, but you're reduced risk for atherosclerotic renal artery disease. If you have the G allele, it's the opposite. You're at an increased risk for atherosclerotic coronary artery disease. This has been described not just in cervical artery dissection, FMD, and migraine, but now SCAD. And this was independently confirmed in 5 different groups across both the US, UK, Europe, and Australia. There's some other interesting data coming out on the genetics of FMD. I should make the point that this is definitely a polygenic disease. It's not going to be one gene that's causing all the variety of manifestations. This was an interesting study looking at a loss of function mutation for this prostacyclin receptor. They identified it first in related patients with FMD and then confirmed it in non-related patients across US and Europe. And what they found was that this mutation was enriched in patients with fibromuscular dysplasia and also identified in some patients with spontaneous coronary artery dissection. And the cool thing about it is that it makes sense in terms of the function of this. So it's involved with vasodilatation, fibrosis, smooth muscle cell proliferation, and platelet aggregation. So it's an interesting finding, and I think we're hitting just the tip of the iceberg with all of this. And then lastly, there was a recent identification of a variant in a COL5A1 gene, which is associated with classical Ehlers-Danlos syndrome, that was identified in patients with multifocal FMD and arterial dissection, as well as those with arterial dissection alone. So these variants may be pathogenic or disease modifying. It's not really clear yet how this is going to play out. But that brings me to our DEFINE FMD trial at Mount Sinai. So this was something we started about 10 years ago. It's investigator initiated. We recruit patients through our FMD clinic with myself and Dr. Olin. Our initial funding is really through philanthropy. We got some NIH funding now to support the basic science work. But the goal of this study is to study the functional, molecular, and genetic profile of fibroblasts from FMD patients compared to matched controls. We expanded it now based on the data that's been coming out to include patients with cervical artery dissection and SCAD as well, to try to understand the overlap and crosstalk between these. So we're targeting patients with FMD as well as SCAD, cervical artery dissection, and then controls. All of the controls are evaluated for any suspicious family history. They all get their neck and belly listened to for bruits, which is how we found some hidden FMD in a few of them, and blood pressure. And then we match the patients by sex, race, ethnicity, age, smoking, and BMI and medications. All patients get a punch skin biopsy that gets sent off to our lab where it's plated and then grown out. And here's an example of a piece of skin with some fibroblasts extending out. And from this, we're able to get RNA sequencing, and DNA from the whole blood. And everything is handled by a single person. This is Valentina. She does all of the lab work for our patients. And so today we have a total of 439 patients enrolled in our study, just about 263 with FMD SCAD and cervical artery dissection, a little less on the control side, but we are recruiting about 1 to 2 a week, and we've been making really good progress, I think, with this. Some data that we're coming out from this endeavor. Basically, they're able to look at the differentially expressed genes in cases versus controls. We found 273 different, as you can see on this volcano plot, the most significant and farther out here in patients genes increased in FMD versus controls. And we had a paper come out a little over a couple years ago, I guess now, in which we were able to identify 37 different proteins and 10 lipid subclasses that had differential abundance in patients with FMD versus the controls. 5 of those proteins showed genetic control and were determined to be upstream of FMD and probably important in controlling the disease. This one protein, the CD2AP, was independently validated with risk of FMD. And it's interesting because it's expressed on the endothelium of medium to large arteries. They then did a lot of fancy stuff that's above my pay grade with machine learning to basically develop a test for FMD that you potentially could do to see if the patient was at risk for having FMD or not. And it had a C statistic of 0.73. So pretty exciting that we may someday be able to identify who we should be screening with a blood test. I just want to acknowledge Dr. Kovacic. He's the PI for the study. He's the director of the Victor Chang Institute, still holds a position at Mount Sinai as well, where his lab doing this DEFINE FMD research is functioning. Valentina, Dr. Olin, my mentor and senior partner, and then Annette King, who does all of the actual biopsies for enrollment, and one of our great fellows, Catherine Michaelis, and many other people who've collaborated with us on this. So it's been exciting work. I'm going to move towards the management and follow-up of FMD, which is where I think most of what the patients want to know. So in terms of the management of vascular findings, when it comes to aneurysm, there's nothing specific for FMD patients. So you're really following general guidelines in terms of surveillance versus repair and all of those type of things. However, just keeping in mind that if there are multiple findings in a single patient, you may want to consider genetic testing. If they do have a heritable arteriopathy and not FMD, like vascular Ehlers-Danlos, it may change thresholds for repair. When it comes to dissection, if it's incidentally identified, aspirin 81 milligrams a day is all I do. For the acute symptomatic extracoronary dissection that is not in the intracranial circulation, I tend towards anticoagulation over antiplatelet therapy. There's a lot of controversy about that, but it ends up being case specific. And then your surveillance is going to depend on whether or not there's any high-risk features. For other findings, aneurysm dissection, tortuosity, aortic arch anomalies, lifestyle modifications, which I'll talk to you about, and then again, aspirin 81 milligrams daily. So this is what we do not want our patients to do, right? So what I tell them, and I give them a sheet with all of this, basically, try to avoid intense isometric exercise or extreme Valsalva. Don't lift to the point that you're holding your breath or grunting to lift something. We have good data, physiologic data showing you can generate mean pressures upwards of 300 millimeters of mercury if you do that. Everybody's ability to lift is a little bit different, so I don't give them a number, but I say if you have to really Valsalva to lift something, too much for you. Chiropractic neck manipulation, avoid. Cardio exercise, I tell my patients to warm up, cool down, and then if they want to monitor their heart rate, I ask them to try not to push themselves above 80% of their maximum predicted heart rate. For patients who don't want to watch their heart rate or that's a little too much, I tell them if you can complete a sentence without huffing and puffing, you're in a safe zone cardio-wise. High G-force activities, roller coasters, etc. I also tell them to avoid. We've had some patients have dissections after that. Scuba diving, another thing I also will tell patients to avoid. And then I put as an allergy in their medical record, quinolone antibiotics, and I just write avoid if possible due to the increased risk of dissection. There was a warning that came out from the FDA a number of years ago showing that there was this dose-dependent, duration-dependent increased risk for aneurysm and dissection, particularly for patients with genetic arteriopathies. I put FMD in that category, and that's why I make that recommendation. Same for patients with peripheral artery dissection. And then in terms of general management overall, all patients with FMD, regardless of aneurysm or dissection, gets put on aspirin 81 milligrams a day. I follow them up initially every 6 months for the first year, and then I go annual, and then if they're really doing well, every 2 years after that. I used to get imaging every time I saw them with ultrasound. I've moved away from that, and I'll show you some data to support that, unless there's something going on clinically that makes me think I need to look again. Hypertension and FMD. I rarely send patients for intervention these days, unless they've got new onset hypertension, like less than 2 years, or resistant and labile hypertension. I'm not sending them for renal angioplasty. And this is a population that you really want to avoid stenting in because, again, we're in the mid to distal artery most times. Stent fractures happen frequently for these patients, as well as dissections. They're not normal arteries. So usually angioplasty alone if you are going to do something. So here's the data on follow-up and screening these patients repeatedly. We looked in our institution at almost 150 patients that had at least one carotid duplex exam. The demographics were very representative of the US registry. We mostly saw carotid and renal involvement. About 35% had aneurysms and dissections. Most were multifocal. They were followed for almost 3 years or a little over 3 years, mean follow-up, and had at least 4 ultrasounds in many cases on repeat exam. And what we found was that a new carotid dissection occurred in 3 patients, 2 of which had had dissections in other arterial beds. So that may just be the way that their FMD behaves. There was no change in the appearance of FMD on repeat duplex, and not a single patient developed new beating in an artery that did not have one at diagnosis. So it's not clear why the arteries change or when they change over a person's lifetime up to the point of diagnosis, but it seems like once that happens, it stops based on the information we have today. Now, thinking about hypertension and FMD, a really important point to make You can't assign a percent stenosis in FMD to a patient without invasive imaging, invasive measurement. So duplex won't give that to you. There's no duplex criteria for the mid to distal artery in the carotids or the renals. And looking at it on CTA doesn't tell you what the overall effect of those multifocal lesions is. The only way you can tell is through an intra-arterial pressure gradient, FFR, something like that. So I have here 4 different renal arteries. You know, I would have guessed that this is the most mild, but actually this one has a gradient of 30 versus 52, and here we've got no gradient. So we really can't tell by looking. And I would avoid that oculostenotic reflex when you're treating these patients and just go off of the gradient. And then the reason behind not sending most patients for angioplasty is this. So as the age of the patient increases, your probability of hypertension cure goes down. Just because these patients have FMD doesn't mean they don't have essential hypertension as well. So unless the hypertension is really difficult to control with medication or labile, I tend not to send the patient for angioplasty. So bringing me back to the beginning, which of these is FMD? All of them can be. The top 2 definitely are, focal and multifocal lesion. The arterial tortuosity, again, frequent in patients with FMD. Intracranial aneurysm, frequent, and SCAD, frequent. But the bottom 3 need to be evaluated for these pathognomonic findings before you can say that they have FMD. I'll just remind you of this family that I follow. It's definitely expanding phenotype, and I think it's much more common than we've realized, especially because of this. There's probably a lot of people out there who are like sister number 3. So in summary, FMD is a systemic arteriopathy that can prevent with these multifocal focal lesions, tortuosity, aneurysm, or dissection. Importantly, if you have multifocal or focal FMD in one arterial bed and the other manifestations of aneurysm, dissection, or tortuosity in another, that's multi-site involvement. All patients with FMD should be getting head to pelvis, ideally CTA, to look for occult aneurysm, dissection, or sites of FMD involvement. And spontaneous arterial dissection and or aneurysm are signs of an underlying arteriopathy, and we should be screening those patients for other findings. And the reason is this systematic imaging allows us to correctly diagnose or identify patients that might need further evaluation, for example, with genetic testing, may help us to find lesions that require continuous monitoring or affect patient care, particularly thinking about family planning or family screening. And it may allow us to better prognosticate patients in isolated versus systemic findings, although we definitely need more data. This is my algorithm. If I see a patient with spontaneous dissection or aneurysm, I get them head to pelvis imaging. If they have FMD, I go down and I follow the regular guidelines for surveillance. If they don't, I start asking myself, did they have aortic enlargement, other aneurysm dissection, tortuosity, which is not always reported. You often need to look at your own imaging to detect that. Suspicious family history or any physical signs or symptoms of a connective tissue disease. Any of those positive, they get genetic testing. If it's not, then they fall into this FMD group as well for follow-up. And with that, I thank you very much for your attention.